Thank you for those kind and obviously false remarks about, but I appreciate that. As mentioned, I'm here today to talk about medication exposure in pregnancy risk evaluation program. And I know that there's been a call to ban acronyms, and this is probably one more reason to ban acronyms, because I think we tortured this so that it became some type of word, MEPREP. I can't tell you the number of times I've had to email the principal investigator to ask her to remind me what MEPREP stands for. Medication Exposure in Pregnancy Risk Evaluation Program. It seems like it's a licensing test for physicians, though. That's what for some reason it reminds me of that. Anyway, thank you for having me here. This is what I thought I'd be facing when I realized that I'd be in the last session today. So thank you very much for attending, and it looks like the turnout's a bit better than expected. So I'm happy that you're here. Let me tell you a little bit about a fairy tale that I had. I don't know, let's see. So this is Sophie, she's 2 here. This was 8 years ago. And you could tell who has the energy in this photograph and who is clearly on their last legs. But this was during the time when this post-marketing surveillance study was really just simply that, a fairy tale. And I put this on because somebody mentioned today that this program really is a miracle. And I can't tell you how exciting and gratifying it is to see that it's come about. When I was in medical school in the early 80s, I had assumed, for absolutely no reason, that this kind of surveillance system already existed, and because it just made absolutely no sense that we would be treating women during pregnancy with medications and that there would be no information on the safety of those medications. One of many assumptions I made in medical school that were completely wrong. I mean, it was absolutely absent. And so one of the things we started doing in conjunction with actually a number of other large networks that are being designed and created to look at drug safety in the United States and vaccine safety in the United States is this new, very gratifying program to look at medication exposure during pregnancy and the safety of that. As you've heard, knowledge of safe medication use during pregnancy is limited. There's about 2 out of every 3 women, maybe slightly less, take at least one prescription medication during pregnancy, which is really, that sort of opened my eyes to the need to this when we first collected that information. And there have really been a substantial lack of rigorous studies evaluating the birth outcomes associated with in utero exposure to medications. So we were actually doing a number of studies with Scotch tape and paper clips in the United States, and about once a year we would call up the FDA and ask them to give us a couple $1,000 so we could do chart review to validate some of the medical records that we were finding in various studies we were doing. We did one study on SSRIs and tricyclic antidepressants in pregnancy, and we were doing another study on calcium channel blockers and beta blockers during pregnancy. One's been published, the other is under submission. But we were coming back to the FDA repeatedly to ask them just to give us some money to do some chart review, and they finally said, look, we don't want to do this anymore. We're glad that you're doing it, but we'd rather fund a large network to do this systematically and to develop an ongoing relationship to do a number of these studies, not just the ones that you tell us about that you need a little money to tie up some loose ends at the end, which is it's a great kind of response to get from a federal agency. So we worked with them over 2 years to develop this program, and we launched the program a year ago. And it's really, it's a mechanism for collaborative pharmacoepidemiologic research that's aimed to address the safety of pharmaceutical products and the development of standardized data requirements and necessary data linkages of mother-infant pairs, and to look at this across many different sites. Well, that's a mouthful. What do we really mean? So there are 3 research centers that comprise MEPREP. The first is, let's actually start from the ground up, from the bottom up. It makes more sense that way. We have Kaiser Northern and Kaiser in Southern California. Those are the 2 biggest Kaisers. They exist in California. There are about 8 million people in that population. So right off the bat, that's a fairly large, substantial group of members who are involved in this program. And then we have the Tennessee Medicaid population. Bill Cooper is leading that work at Vanderbilt University, and that's a very substantial size. And then we have 8 health plans, 8 other HMOs within what's called the HMO Research Network, CERT, which is just another acronym, but it's the Center for Education and Research on Therapeutics. It's just a group of 8 health plans that actually gets together. Actually, we usually have Kaiser, Northern and Southern California involved as well, but that's beside the point, to do research on drug safety and drug effectiveness and comparative effectiveness. But for this program, we're coming in to look at drug safety during pregnancy. So there are 11 different HMOs, or 10 HMOs plus the Tennessee Medicaid population. Right now, so the first thing to say is that we have this is going to be an ongoing project. It's not a specific study at this point in time. It's an ongoing project. Right now, we've collected data. I'll show you some data at the end of the talk. But we are collecting information on the members of the health plans who meet the following criteria. That is, a woman was pregnant and delivered an infant between 1/1/2001 and December 31st, 2007. So we've taken all those women and the children born to the women identified above. And as all of you know who do research, the slides are always a lot easier to do than the work. This little statement that we collect their children is actually incredibly difficult to match the babies to the mothers in these health plan files. I won't go into it except to say that a lot of babies are born if the dad's in the health plan but the mom's not in the health plan. There's no mother to the baby that we can find in our enrollment file. Sometimes babies are born with the dad's last name given. Sometimes they're born with the mom's last name. Sometimes the baby is baby John Doe because there's no name assigned, or there's just baby boy Davis or something in our situation when we can agree on the name of our son. So finally I got smart and I lost that battle. So okay, so moving right along. So what we've done is we've linked the infants to the mothers of all women, and now we're linking it to the birth certificates because there's actually good data on the birth certificates in the United States. Frequently what happens is that there's a nurse in each hospital who interviews the mother about smoking and drinking habits, some questions about family history, a number of other things, careful, although not always correct, elucidation of the race of the mother and the father, and that data is entered onto the birth certificate. So that's good data for us to link to when we can. And now we've also embarked on validating the data elements within the data sets through medical record review, and we could talk about that more later. And now we're just starting our annual update of the data sets so that, as I've said, we have data from 01 to 07, and we're adding 08 right now. Okay, so I thought I would tell you about the development of the program in terms of the governance and then the organizational structure, the study policies, and then how we're creating our standardized databases. And I know that a number of you are thinking, boy, that doesn't really sound all that interesting. And honestly, it's not. So just fair warning, it's not the world's most interesting stuff, but this slide is to remind me of some big problems we've had in the past when we launched into studies without really thinking a lot about study data set creation and governance. So for example, the first large linked database, so this is a large linked database where we're linking data across 11 HMOs. The first large linked database I was involved in started in 1994. It was called the Vaccine Safety Data Link. Has anybody here ever heard of that? Oh, okay, well, I guess it's not that famous, but in vaccine meetings, it's well known. How's that? And we linked up eight HMOs, and we're studying 5% of the children and adults in the United States, about 13 million people under observation at any given time, and we're looking at vaccine safety, and I'm already off the point. But we used to get all our data and send it to the CDC, because they were the funder, and we used to combine all the data, send it to the CDC. And then one day we realized when the big thimerosal issue blew up, and who here knows about the thimerosal autism? Aha, okay, well, we are responsible for that, so I apologize. But so we got involved in the thimerosal autism issue, and it turned out that a congressman wanted to subpoena our data because he was convinced that we were covering up the relationship between thimerosal and autism. We said, well, you can't subpoena our data. It's a scientific study. And he said, of course I could subpoena your data. It exists at the CDC. The CDC is under federal control. And it turns out he was right. We were wrong. He could subpoena the data. So long story short, we actually dodged that bullet. We convinced him not to subpoena the data because that would have killed the study. But it made us realize that we should never send our data outside of our HMOs again, because it's completely identifiable, it's HIPAA non-compliant, et cetera, et cetera. So now our data for all these 11 HMOs sits behind our HMO firewalls. And when people want to do these big studies, and we'll get into these big studies in a second, what we do is we've spent literally millions of dollars and tens of thousands of man hours over the last 20 years making our data sets almost identical across all these different sites. So to the extent that a single programmer in any of the different HMO research centers could write a SAS program, submit it across all the different 11 sites, and pull back an analytic data set. And that's suitable for study. So there's really no reason for us to combine data and send it to the federal government anymore. But that was born out of hard experience, which is the reason why we have a steering committee. So that was a long introduction to why we have a steering committee. We have a steering committee to think about issues like this. And within the steering committee, we have a technical working group, a coordinating center, and then the investigator groups. Now, the organizational structure for the steering committee, they are the primary leaders of the program, and it's made up of representatives from each of the research centers and the FDA, and they're the ones who decide what we're going to study. They have to approve the study protocols, they have to review the abstracts and presentations and manuscripts, and we decide together on issues of publicity and public relations and media releases. And then we have the technical working group, and they're the ones who really have been spending a lot of time trying to make sure that the data that exists at each of the sites means what it says it means, and that the variables are all in order and identical across sites. And we are now currently validating these data elements across sites. Then we have the coordinating center, and that basically is the group that is facilitating and organizing our program activities, such as the development of our program data sets. They're the ones who are writing the programs, sending them out to the different HMOs, pulling back the analytic data files so that we could analyze our data. So they're really the ones, or we are the ones who are involved in study design, statistical analysis, and data processing. And then we have the investigator groups, which are the investigators from each of the 11 HMOs. And we're the ones who take responsibility for really choosing the principal investigators on any specific study, whether we want to do it, whether somebody at the FDA wants to lead a study, et cetera. That's the group that really decides who's going to lead and then who's going to follow with any particular study. We've actually written a number of policies having to do with publications, how we share data, how we collaborate with people like you, outside investigators who might be interested in doing a study on something that you're interested in, and how we deal with conflict of interest. A number of us do work with industry and do work with other federal agencies like the CDC or NIH who would like to use these data sets as well. And they present all sorts of opportunities for conflict of interest. And so we've tried to be as transparent and open about that as possible. And of course, we assiduously guard patient confidentiality, because this data is actually highly identifiable, and if it ever escaped that a mother could be identified and was taking some medication that made it into the front page of our local newspaper, our study would obviously be in deep water and would likely have to be shut down or at least suspended for a time being. Okay, now we've spent a lot of time talking about data development and working on the data extraction process. We link the mothers and the infants using a series of different methods that have different degrees of certainty as to the linkage, and we create a study ID that's specific to the linkage of the mother and the baby. And then we have when I was talking about these files that exist behind the firewalls at each of the HMOs, that's called our virtual data warehouse. And by virtual means it just is not something that is accessible from the outside. And that these files now contain information on linked mothers and infants for 8 years, from 2000 to 2007, so they include the first year prior to the first possible delivery. excuse me, so we have information on mothers who exist in 2000 but who delivered first in 2001. And so, for example, if we're interested in finding mothers who are diabetic or mothers who have hypertension, we would go back to 2000 and get information on those comorbidities among the mothers in the data files. So this is the data that we actually have then. So we have the mothers and the infants linked in the linkage file. We have demographic information, so we know age, race, gender, obviously. We know when mothers and babies are enrolled in the health plan, so we can validate how certain we are that we've been able to follow them up with the requisite time when we are looking for certain conditions. We have a pharmacy dispensing file, so we know all the medications, and that's that the mother has taken during pregnancy and that the mother took before pregnancy. We have the diagnoses of the mother and the diagnoses of the infant, so congenital anomalies, perinatal conditions, infantile conditions in the first year of life, conditions for as long as a child is enrolled in the health plan, we collect. If the mother or the baby are admitted to the hospital, we get that information. If the mother or the baby undergo any procedures, any surgeries, we get that information. I talked about the birth certificate, and we have a crosswalk that allows us to link all this together. So this is how it works, really. We have, I told you about this linkage process. So we have a study ID that basically allows you to basically go in and pull out data on gender and race from the demographic file, link it to the enrollment files, link it to the dispensing files, diagnoses files, et cetera, and create a large file on any particular baby. There's a crosswalk where the study ID that we create is linked to the medical record number, and that's kept completely separate. So all this data is de-identified, and this is how we would re-identify it if we had to, but we hope we never have to. And then from the birth hospitalization of the baby, we have over 100 variables on birth information, mother and father demographic and comorbidity information, complications of pregnancy, labor, and delivery, information on congenital anomalies and other perinatal events. Okay, so right now we are working in this, we're just ending the first year of kicking this project off. We are validating certain elements in our data sets. We just finished pulling a couple hundred charts at each HMO and validating certain variables to make sure that the variables such as smoking status and mother's age or certain diagnoses such as congenital heart disease actually mean what we believe them to mean. And we're also drafting a manuscript to describe MEPREP to the general medical community. We are working to identify deliveries at all the HMO Research Network sites, and we're performing quality checks on the administrative and birth certificate data so that we're making sure that, for example, mothers aren't less than 10 years old, mothers aren't over 99 years old, babies aren't born at over 10 pounds, things like that. And then we have ongoing documentation of all the data quality steps that we're taking. So currently we have the mother-infant linkage process completed. We have the administrative files completed. We have birth certificate data collected for some years. We're hoping to update it through 2008 by the end of this summer, and our documentation is underway. Okay, so you've survived the sort of dry data-driven part, and now I thought I would stimulate you perhaps and just show you a little bit of data, because after all, what is this without a little bit of data? So we have, this is the fun part where I get to say we actually have data on over 1 million mothers linked to babies, and we have information on all the medications that those mothers took, and we know by and large what happened to the babies. So that's sort of gives me goosebumps every time I say it. It's kind of neat. 1,045,373. Eventually we'll get one of those little counters so we could automatically update it so it would slowly grow while I give the talk. Kind of fun. And here's the population, just to show you a little bit of data. So, for example, an OBGYN was in my office the other day saying that she had gotten her master's in epidemiology, and she was very interested in looking at the outcomes of infants born to mothers who were very old. And this is where life just gets cruel. So then the conversation, well, what's very old? Well, over 45. I was like, okay, thanks very much. This is what I don't really need to know. So, but it was joking, of course. But one of the sort of nice ancillary benefits of this data set is that we don't have 290,000 mothers over 40, but we do have 29,000. And so we could look at things like birth weight and fetal growth, congenital anomalies, perinatal conditions, et cetera, with a modest degree of power. And I guess I'm sort of showing my bias. We'd like to have more. We will have more in a couple years, but right now this is a fairly substantial data set that we could look at both things like maternal age and its effect on pregnancy outcomes, but also medications used by let's see, what should we call this? Women in the prime of life who are having babies? Okay, I'm going to move right along before I get into real trouble. All right, so this is another study that this is a study that we're actually just about to start. This is a feasibility study that we're doing, looking at so the feasibility is just what kind of statistical power do we have to address certain questions. So this is the number of mothers that we have linked to infants where we have medication exposure to antidepressants during pregnancy. So we have close to 50,000 infants who were born whose mothers took SSRIs. We have 6,693 mothers who took tricyclics, 203 who took monoamine oxidase inhibitors, 17,000 took other medications used for depression that aren't classified according to these categories, and then 8,000 probably took some combination of SSRIs and tricyclics. So they would, in any study, we would sort of allocate them accordingly. And then we have 957,000 comparison non-exposed women who, 2/3 of which took some other medication, but just not antidepressants. So why am I particularly interested in this? Well, there's still a controversy over whether SSRIs are associated with congenital anomalies during congenital heart defects. Every single study that's been out there has been underpowered, and I'm speaking as one who has published on this, and we had a negative study, but it had limited power to rule out an elevated risk that was modest yet clinically significant. So it wasn't particularly satisfactory. So we hope to readdress this now with a substantially larger population. The study we did previously was on 100,000 babies total, of which we had about 2,000 who took SSRIs. Here we have 50,000 babies who took whose mothers took SSRIs. So this is a magnitude increase in our statistical power to address these sorts of questions, and that's just to sort of show you where we are. So unfortunately, I can't show you the results of that study because we haven't done it yet. But come back, invite me back again if you could tolerate my sense of humor, and I'll be happy to show you the results in a couple years. So that's where we are. Thank you very much for inviting me. And conclusions. What we really really just to sort of summarize, we're enabling the analysis of compatible data in multi-site studies, and we're building on now 15 years of experience in linking data across HMOs. And we're doing it for the Sentinel Initiative for drug safety in the United States, for vaccine safety, and now we're doing it for drug safety during pregnancy. So that, I think, is something that is a real nice development. And we believe that it'll be important for the evaluation of birth outcomes associated with medication use during pregnancy, but also to measure the patterns and trends in medication use during pregnancy. So thank you very much. I'll be happy to take questions. Sir. My kids who have to tolerate my sense of humor daily at home. So thanks.
Thank you very much, Dr. Davis. Numbers are, of course, very impressive, so people often are impressed by the numbers as they should. But let me give you a scenario and ask you how you deal with this. The SSRIs are blamed or believed or partially believed to have more cardiac malformations. The most common is VSD, which is the most common cardiac malformation, which in 90% goes away after 2 years because it's closed. Over the last 5 years, women are told that it causes it. So a woman that take Paxil or venlafaxine are rushing to find the diagnosis. So on your system, you'll find more women that had Paxil, that went to their physicians and had the ultrasound and this and that, and guess what? They have it. The control group didn't because they didn't go to check. And if they go 2 years later, it's not there anywhere. So here is an example that the data, as impressive it is, has a clear bias, ascertainment bias, which the system cannot overcome. Or how are you going to overcome it?
No, so thank you. You articulated it very nicely. That's an inherent bias in these sorts of studies, sort of a diagnostic bias or an increased workup of children who are exposed. So this is not a perfect system, and even though I get excited about it, I get excited about it, which helps me sort of get up every morning and go to work and do the work, but it doesn't overcome by itself these issues. If you ask me, how would we address this, I would probably say, well, one way would be, for example, to look at VSDs that are clinically significant, that are actually associated with shortness of breath or increased pulmonary blood flow or any of the things that we might say will come to clinical diagnosis regardless of the mother's suspicions. You might also say, well, let's also we'll limit it to infants who are hospitalized, because they're clinically unwell. So there are ways of teasing that out, but you never know for sure whether the bias is so strong to overwhelm that. So that's one thing. The second thing is that, I see this as, so this isn't perfect. Case control studies that are based on maternal recall suffer from a different type of bias. It's not really one or the other. It's both working together. And if lots of different studies from almost different cultures say the same thing, I believe it. But I must say that the older I get, the more suspicious I get of single studies that show these sorts of things, because they are prone to and this is just one of many other biases.
Hi. So I just wanted to ask you, and I'm familiar with your work, as you might know, what are you going to do about confirming if the women actually took the drug? I'm sure everybody says this to you, and I'm sure, and I know, but I mean, we do know, and especially at Mother Risk, we do know that women, especially the psychiatric drugs, if they're not going to take a drug, that's going to be one they don't take. And so are you going to have any planners, maybe, say ones that had birth defects, like call them back to confirm they actually took the drug? I don't know, it's just
So great question. Right, so the real benefit of this program is not the data as much as it is the fact that we have probably 2 investigators at each site who has their own ideas of what studies they'd like to do, and somebody is interested in that question. And I mean that because honestly, a good data set with 10,000 people with good ideas and good data is just as good as anything that we could put together. So one of us, I know, I think maybe even Bill Cooper is interested in this. In our initial study, when we looked at SSRIs, we were able to validate that a substantial number of the mothers who got SSRIs refilled their prescription at least once, which suggests that they're taking them, that they come in. Because why would you refill it unless you sort of had, there are reasons to refill it, but we are able to track refills during pregnancy. But a lot do stop, and a lot do stop within the first trimester. And we don't really know, it's really difficult when they get that prescription in the first couple of weeks of when they're pregnant, even though they don't know they're pregnant, and then they never refill it again. Boy, that's really interesting. We'd love to know whether they took it or not, but we don't know. Now, we know that they have a possibility of exposure, so we might want to do some nested surveys of the mothers. Do you remember? But then we're back to these other biases. A mother who has a baby with gastroschisis, will be thinking and will be racking their brain of everything that they took in the first trimester. So it's this trade-off.
Dr. Davis, thank you very much for your presentation. So this is great, but I don't know if you can answer this, but so what's the next step? Is there's, in terms of labeling and making your information available to the average prescriber, where is the FDA with this?
I'm not sure that I know the answer to that. I'm trying to figure out what I could say that's likely to actually come into place, because certainly we will be doing studies. We'll probably, soon, these things have just these incredible gestation periods, and then all of a sudden 5 studies actually get started, and then more studies get started, and pretty soon you actually have an active research branch that's pumping out data every year, and hopefully we're going to get to that point soon. We're not there yet, and it's been frustrating, but it's actually been a good thing to start this slowly, so we sort of avoid all the terrible problems that we've had in these other large networks when we've just launched, we've gotten excited and we've launched in right away. If it were up to me, I would probably do something, well, in the past, I've wanted to say, well, let's create a website and let's put our data on the web, because there's a tremendous amount of information that already exists in our data. And there's a lot to be said for that. I'm not sure I'm answering your question, but I'll get around to it in a second. There's a lot to be said for that, but there's also a lot to be said for not doing it, because it raises so many questions and it causes so much alarm. And even though you know what it means as a scientist, a lot of people don't. And I'm just always amazed at the divide between scientists and not scientists. Not that I know how to do anything in life very well except science, but I do know that a lot of people seem to have endless ways of misinterpreting science. So there are probably reasons not to put up scientific information on the web and just let it out there until we get to the studies. So that said, I think that the FDA will probably do this in a very systematic process. Now we're getting to this issue. If we do find, let's say we skip forward ahead 2 years from now, and we do find that there's a doubling in the risk of VSD among mothers who take SSRIs, I think then that's when you do a cost-benefit, not a cost-benefit, but a risk-benefit study where you are systematic, where you're really drilling down into what the risks are of mothers who come off of antidepressants. And I imagine that the risk is going to be at least tenfold higher to the baby and to the mother of a mother coming off antidepressants. So, in the first study we do, when we show the risk, we always sort of try to make sure we put in a disclaimer of saying, we're looking for risk here. We're not looking for benefit. This is not a risk-benefit study. And then it has to be followed by the risk-benefit. And then it really gets turned over to the FDA, who decides, does this go on to the labeling, or do we actually do something like with ACE inhibitors or other issues where we actually strictly try and control who's using it during pregnancy? Good. Thank you.